Good afternoon, everybody. Thank you once again, sir, for that kind introduction. Whenever we talk about cardiac MR in India, we always take sir's name, so it's an honor indeed to be here. I'm from the CARE group. This is our hospital at Road number 1, Banjara Hills. This is the kind of pattern of studies that we have at our institution, and you'll see that a large chunk of these studies are basically that of viability, and the rest is sort of compartmentalized into cardiomyopathies. We've got some leading projects on cardiomyopathies, especially tuberculosis and sarcoid, valvular heart disease, and also congenital. I just want to make a small comment like Dr. Vijay did in the last session before lunch, in that we have been slowly moving away from cardiac MR for the congenital heart disease group. We have a large congenital heart disease population because we work in the ambit of the government Arogya Shri scheme, which does give a cardiac surgery free of cost to the underprivileged people. So there's a lot of those children that we image, and because we have this dual source CT, we have been sort of moving away these children from the cardiac MR to CT, and I will just show you some of the reasons. So a good amount of work is a little earlier work. Recently we have more of CT, but nonetheless I'll just try to cover the important aspects of congenital MR imaging, and this is a workflow which has sort of increased over the last 5 years. We've been in MR for the last 5 years. So just briefly, you're all aware, but I'm just going to go through the brief advantages of MR, the contrast resolution, no attenuation problems, no window issues. Not a major issue for congenital heart disease, but nonetheless to complete the list. Tissue characterization is a very important aspect of MR, and the most important thing in this group of individuals, no ionizing radiation. Problems with MR, we all know the relative cost. Even at our own institution, MR is much costlier than CT, limited availability of MR scanners compared to CT, very long scan times, and this is something we've been having a problem because our children are very, very young, 2 month, 1 month, some are a few days old, and then it's very difficult to anesthetize them and keep them that way. Devices not a problem in this population, and certified physicians. So today my brief has been to talk about imaging of the young heart, and I will just try to go over some of the basic things that we do when we image them, and some of our own collections. So this is a study at our own institution which we presented in last year CSI meeting. And this is the kind of cross-sectional pattern of our congenital heart disease workflow at the MR and CT, which I take care of. And you can see the largest group is the group with pulmonary atresia, complex heart disease, pulmonary atresia with or without confluent pulmonary arteries. And this seems to be the largest group, which in echocardiography has a significant limitation to delineate the pulmonary arteries, to delineate the feeder vessels, to delineate the MAPCAs. The second group are the complex tetralogies with or without associated lesions, and also with very small pulmonary arteries, which are again very difficult to delineate. And the biggest takers of our program are not our cardiology group, but the cardiac surgeons, who are very, very happy with the images. The third largest group are the aortic studies, coarctation and complex coarcts with or without a PDA with the VSD. And MR can do a great job about delineating this. And the other complex congenital heart disease, especially we have a large group of TGAs which we try to do early arterial switch operations, and we look at them fairly frequently along their life span to look at the LV function. And we also have atrial switches where we have to operate these children later, and we do an atrial switch rather than an arterial switch. And here the RV is the systemic chamber, so sequential MRIs yearly or every 6 months we do them to assess the RV function, which is difficult to do in any other modality. So this is the kind of cross-section that we have. And the choice of imaging, this is our center specific again experience which we presented, is when it comes to a pulmonary artery, especially very small pulmonary artery, we are preferring CT. We're using a dual source scanner, and with the optimized parameters, we are doing it at about less than 2 millisieverts. So we're preferring CT over MRI, whereas aortic studies, generally we do an MR first unless there is some other problem. This is the kind of cross-section that we have, where the MR or CT has added on to what the echocardiography has already done. And you can see in all the cross-sectional work of pediatric cardiology, that is pulmonary atresia, aortic anomalies including aortic atresia and coarcts, and pulmonary venous abnormalities, and systemic venous abnormalities and complex PDAs. The MR and CT have added significantly to the diagnosis, added significantly to the plan for surgery or for medical management. So there's a significant add-on value when you add an MR or CT in this particular population, especially very distinctly in pulmonary venous and systemic venous abnormalities. I just recall a case 2 days ago where an echo was reported as nearly normal outside. It was a neonate with a lower respiratory tract infection. And then when we did an MR, we found a total anomalous pulmonary venous connection. And this child had a successful surgery today. So MR versus CT, it is always a sort of challenge for us because of a few issues. So I'm just going to go through some of the important highlights between both, and it also helps us to choose. So we know the obvious things which I already mentioned, but we have an MR scanner and we don't have a dedicated pediatric coil, so we just sort of manage with the other coils which are available. And so for the smallest infants, we really try to avoid MRI because of the coil problem, the resolution problem, and also because the MR studies take at least 30 to 40 minutes. These are congenital, these are very complex congenital hearts, and they require a lot of segmentation, so we prefer CT in this group. And these are basic sort of protocols for both. The contrast radiation being nil here, and we are able to do our children less than 2 millisieverts. And the most important thing I felt as a cardiologist is the 8-second or 6 to 7-second time for the scan for CT, and it takes almost up to 45 minutes for the complex things to be imaged, babies to be imaged by MR, and that is a huge straightaway advantage of CT, and our anesthesia team is extremely happy when we say we're going to do a CT scan of this infant rather than an MR. Also critical neonates, I think there was a nice picture of a neonate on an incubator, and we don't own such an incubator, but critical neonates who are critical, infants who are critical, CT is a better option because we can get away with a very quick scan, and we can have all the paraphernalia equipment in the CT scan, and we don't have that facility in MR, and cost also is an issue. So briefly going through some of the MR sequences, basically we start with the localizer and go on to the haste. We take the sections, axial, coronal and sagittal, from base to apex. Once that is done, we straight away go on to the functional imaging, which is SSFP sequences, and based on whatever haste images we have, we construct the 2-chamber, 3-chamber and 4-chamber, and then do a whole stack of short axis right from the base that is just above the mitral valve and go right down to just below the ventricular apex and include the atria whenever there is a requirement. These are the standard things that we do, following which if there is a mass lesion or there is a mass we want to identify, then we do a T1 and T2 sequence followed by a contrast study, which is generally the most important thing for us, where we give gadolinium at about 0.1 ml per kg with a pressure injector at 2 ml per second, and this is mainly done to delineate the great vessels. Now once we do that, we also go in wherever there is a lesion. For example, there is a PDA or there is a coarctation, we apply the phase contrast imaging sequences, and based on the likely velocities, we change the settings in our machine, and we are able to get the flows and also the velocities across these lesions. So PDA, coarctation, and also in most of our infants we have aortopulmonary collaterals, especially as I told you, we do a lot of pulmonary atresia imaging. So we're able to look at the flows, calculate the flows from them using the phase contrast imaging. We have also, we do that regularly on our coarct patients. We used to look at the significance of stenosis across the coarct, but now what we're doing, and this is something that has been validated also, is that we sample a coarct just below the stenosis, and we do another sampling distally just above the diaphragm, and we're able to find that if the coarct is severe, the severity of coarct on echo correlates with a marked increase in the flow distally just above the diaphragm. We are just going to publish that. So those were the sequences, and always remember that congenital heart disease is very varied. You can't take anything for granted. The systemic veins may or may not be there. The pulmonary veins may attach to the LA or not. So what we do once we have the whole study and we have the notes, the surgical notes or the preoperative cardiology notes are very important. We do some special imaging sequences to cover that particular area. And that's very, very important. So it's important to have a working functional diagnosis of the infant before you take it into the scanner. So that you have a mental picture of, once you've done the standard sequences, what are the additional ones we're going to do. And some of the examples which I'm going to show you are especially if you're dealing with a Fontan repair. These are infants which have the tricuspid atresia, or the right ventricle is too small. They undergo the Fontan repair, and they have extracardiac or intracardiac conduits. And these conduits are very liable to close down, get calcification, get thrombosed. So we need to image them separately, both by the functional imaging and by the cine phase contrast imaging, to get the actual flow. And we also have children who come in with BT shunts, which are possibly getting thrombosed clinically, and then we need to evaluate that shunt. So these are some of the extra things that we need to do. And this is very, very important, that we have a preoperative diagnosis before you take a patient for an MR scanner. We just don't take a fresh sort of infant in just to look for a diagnosis. Most of our infants have an X-ray, ECG, 2D echo done by the pediatric cardiology team, and we have a discussion about what extra they want from the MR, or what additional information they want, or what is something they have not really seen and they feel that's a problem. Especially infants with heart failure, structurally normal hearts are a very good example of the infant's V image, and we find a lot of systemic venous or systemic arterial fistulae which contribute to the high flow and heart failure, the cardiac structures being normal. Pulmonary venous anomalies also are very well picked up with MR, and it's important in the contrast study that we do at least 2 or 3 sequences, the arterial sequence immediately, once injected with a 5 or 6 second delay, and we inject them, we also image them at least twice, and for patients with Fontan we do even a delayed sort of scanning to see the slow venous return in a Fontan. So these are some of the extra things on the console that you have to be aware of, apart from the standard sequences.